My name's Steve Kappa. I'm a patient who suffers from chronic lymphocytic leukemia, and as such I'm susceptible to infections that can be rapidly life-threatening. As a result of chemo treatment, I did catch an infection. I was admitted to hospital, and I spent a week in the hospital. I didn't know when I first went in that I was going to spend a week, and interestingly the staff didn't know that I was going to spend a week either. And that was a process protocol failure that actually meant I stayed in there for a week, which I may come back to. As a patient, I would consider myself reasonably intelligent, quite knowledgeable, and a fairly strong character. And I would say that some of my experiences and my understanding of those experiences might be of use in the future. The place I'd like to start is in A&E, where I'd been admitted, have an infection, protocols in place for treatment, etc. For some reason, people were obsessed with treating me for diabetes. I'm not a diabetic. I've never been a diabetic. I might become a diabetic, but I'm not a diabetic. But 3 different consultants, because I had sort of slightly high sugar levels, insisted I was a diabetic, and that followed me all the way through my stay in hospital. Staff put it on my menus, which I ignored and ordered as much custard and sugar as I could possibly get.
Hi, I'm Elouise Kappa, I'm Steve's wife. I'd like to tell you a bit about my experiences during Steve's stay in hospital recently. On my side, it really was to do with the communication side of things that I had some concerns with. Basically from start to finish during his stay, from A&E through to when he was discharged, there was some limited communications with regards to telling us what was going on a regular basis. At the point of A&E, that was very apparent as I was ending up having to go and seek out a member of staff to ask what was going on, in particular with regards to finding him a bed in an isolation room within the hospital. This was not very forthcoming, and at no point during his time in A&E did anyone come over and explain the situation, or indeed apologise for not coming to us and telling us what was going on. So that's one point. The second point is with regards to communication of Steve's medication. 3 times I told 3 different consultants of his medication, and 3 times obviously the medication list was lost, mislaid, whatever. So that concerned us a little, to the point that when he did finally get moved to a ward, I had to go home and fetch our own medication for Steve to take during his stay. When Steve was moved into the wards, the communication there was a little better, in particular where we got to know certain staff nurses or other members of staff. They would tell us what was going on to the best of their knowledge. But a lot of time we found that they didn't know what was going on either. So for the 7 days he was in hospital, it was quite hard to understand what was really going on a day-to-day basis. There was one particular incident that troubled us a little. It was very apparent that Steve had to have a course of antibiotics during the time he was there, and we were told by the consultant that should be at least 5 days solid. It was stopped a day or so earlier than should have done, but we weren't told that this was going to happen, and we weren't told what the effects of that was going to happen until 2 days after, when the consultant came and found that he didn't complete the drugs he was supposed to have, and we had to start all over again, which basically extended his stay. Then when it came to leaving the hospital and Steve was discharged, I came in the afternoon and saw Steve's consultant from the haematology clinic, and he said, in his own words, "Get him out of here as quick as you can." That was 2 o'clock in the afternoon. We were then told we were waiting for his medication, which was only really to give him back the medication he'd taken during his stay, which was our own medication, not that was prescribed by the hospital. So we thought within an hour or so we'd be out. That wasn't the case. It took till about 6 o'clock. I went to the desk to say, why is he not got his medication? They said, he's not on the screen, they haven't signed the paperwork. This then made me think back to A&E when we were waiting for a side room, and the term was the barrier rooms, isolation rooms, are like gold dust. That made me think, I'm not surprised if you've got people sitting around who are ready to go home and well enough to go home, or utilising a room that should be given to somebody else. We finally left the hospital at 7 o'clock in the evening. But during that whole time on discharge day, again, we weren't kept informed of what was going on or why there was the delay. That, I think, should be remedied, certainly on discharge day when the person just wants to get home and they're well enough to be at home. There should be some sort of communication there to tell us what's going on.
If someone asked me, and someone has asked me, how I would look at improving experiences, for me it would be about communicating expectations. Whether that would be, in my case, an expectation of when I went into A&E, how I would be treated, or onto a ward, how I would be treated, or how long I would be on A&E, or how long I'd be on a ward. That would be extremely useful. You know, if you think about your ordinary life, if you go to a hotel, if you go to shop, you pretty much understand the process. Most people, when they go into hospital, first of all, are worried. They have absolutely no understanding of what's going to happen to them. And I think if hospital staff or medical staff would just sit for 5 minutes and say to people, this is going to be your routine for the next 12 hours or 24 hours or 5 days, that would allow patients to start to interact, and patients could then contribute to their own care and say, okay, I understand you want to do this or that, but what if I did this? Would that help you to help me better? That seems to be a part of communication or practice that just doesn't exist at all. Because I think the assumption is, and I mean this in the best possible way, we're medical staff, we know best, you don't need to know anything, you're just a lump of meat, sit there and we'll deal with it. I don't think that's a good result for the patient and not a good result for the medical staff. So for me it's about expectations and trying to work together as a patient medical staff team to get the best possible outcome. Not just for that patient, but the sooner you treat that patient, the sooner you can get on to treat someone else.